Good evening, friends. In the part of the IAE seminar series, today we have discussed about saline contrast echocardiography, which is actually one of the least commonly used echocardiography in common practice. But I think you have none other than Dr. Saurabh Gupta, who has actually mastered this art with a lot of passion. And I think he has authored a good amount of case reports and usually good review articles in good journals also. So I think without wasting much of time, who is actually the additional professor of cardiology at All India Institute of Medical Sciences. I think I'm Dr. Ramakrishnan. I'm a professor of cardiology. I'll be moderating the session. So I will request all the participants to post the questions if there is any in the chat box. And without wasting much of time, it's over to Dr. Saurabh for his lecture on saline contrast echocardiography.
Thank you, Dr. Ramakrishnan, for the kind introduction. And I must thank Indian Academy of Echocardiography for allowing me to share my thoughts with all the people who have joined the webinar. Now, as Dr. Ramakrishnan said that usually when a lot of people have joined, it's the prime time, and we should not waste. Just to briefly tell about myself, I'm additional professor of cardiology at All India Institute of Medical Sciences, and I give all greetings from AIMS, New Delhi, to all the participants who have joined from different parts of the country and maybe outside the country. Now, when I was given this talk, this part of my preparation is called confusion, because I'm not a great virtual speaker, and you are possibly bored of a lot of webinars you must have had. 1 hour is a long time to keep the interest, especially with a topic like saline contrast echo. Attendees have non-uniform level of expectation, and to connect with hundreds of attendees without seeing is a challenge in itself. So this was my confusion. So I thought that let's try and do something a little different. So if you all become a team with me, then as Shah Rukh Khan said in
70 minute खुदा भी तुमसे वापस नहीं मांग सकता.
So let's try and use these 70 minutes for our own good to learn something about saline contrast echo. Now, before we discuss saline contrast echo, for the benefit of all the participants and to keep the interest, I'll keep putting these little spots in between just to keep the interest alive. So this is the first one. What is in the red circle? You can decide to put your comments in the chat box, or we can discuss subsequently. After a few slides, this will automatically come. Now, before answering this, I'll go to the next one and I'll ask what is A and B. A is this one and B is this one. And if you have any similarity between the two, the lower one is definitely from cardiology. The upper one is not from cardiology, but we all are familiar in one way or the other. Now, before we go to saline contrast echocardiography in itself, let's first focus on evolution of echocardiography. Now, this was the paper editorial written by Harvey Feigenbaum in 1996. And I want to highlight the part on about the contrast echocardiography, which he wrote in 1996. And he said that the field of echocardiography, contrast echocardiography, was started in the University of Rochester with Gremiak and Shah. And according to him, this was an accidental observation which they made, although he also claimed that Joyner was the first one to similarly find the saline contrast echoes, which was later on picked up by Gremiak and Shah, and they worked on it. Now, it was like a sagacity of Gremiak and Shah who took this forward, and this was the image which you just saw. This was the injection which was made in supraortic position in the catheterization laboratory. And as you can see here, this black square is the one which is blood coming out of the ventricle at the time of systole, and this part of the aorta is opacified by the saline contrast at the time of diastole. And like any gentleman, they also acknowledged the contribution of Joyner when they said that Joyner used physiologic saline as an ultrasound contrast medium in the anatomic identification of the mitral valve echo, although Joyner never published it, and this is the only claim which Joyner can make if he is alive today. Now, they didn't stop there. They systematically analyzed the saline contrast echo in 14 men and 18 women. Multiple contrast injections were made in different chambers of the heart, and then there were no patient reactions to intracardiac injection. Now, what is the similarity? Now, let's come back to this fun quiz too. And I think you all would have picked up by now. First one is Alexander Fleming, who discovered penicillin by accident. And second one is Mason-Sones. And this picture is actually the first coronary angiogram which was performed by accident. And I think you all are aware about those accidents. And we know a very beautiful term called serendipity. It is recognized as one of the most beautiful words in the English language. Now, to further dig upon to serendipity, the basic tenets of this word is it occurs by accident and sagacity, by the commitment of the person who is looking forward to the chance finding which he or she has made of things which they were not in quest of. Interestingly, this comes from a tale of three princes of Serendip, and Serendip is the old name of Sri Lanka, and so it has some connection with Indian subcontinent, and that is why I think I wanted to highlight about serendipity. Now, does contrast echo qualify the label of serendipity, as Mr. Feigenbaum claimed in his own article in 1996? Yes, if you look at the accident and the sagacity, or maybe no, if you are critical about in quest of, because anyway, Gramiak and Shah were in the echo, and they would have find it by working on this after a few years. But according to me, this should still be labeled as serendipity. Now, fun quiz 3. What is the opposite of serendipity? And I will not be telling the answer. You can think, find out on the Google if you have time. And if you lose patience in this webinar sometime in between, that you can do for your own good. Now, this was followed by further investigation by investigators like Feigenbaum, who in 1970 published a paper on saline contrast echocardiography to delineate left ventricular myocardium using indocyanine green. And as you would realize that these all investigations were done in the catheterization laboratory. Now, did you realize that initially contrast echo was too invasive and it was possible only in the cath lab? Why? Because intravenous microbubbles don't reach the left heart, and they didn't have a choice but to get into the heart chambers to opacify that. Now, this became clearer how it is safe to give saline on the venous side by these experiments, which said initially that the lung capillaries do not pass any microbubble which are bigger than 22 micromillimeters. And later studies showed that normal lung capillaries are of size of 8 to 15 micrometers. So anything which is bigger than that will not be passed. So saline becomes a candidate for right heart study. Now, yet another ingenious approach by Seward and Tajik in 1976 paved the path for today's peripheral venous contrast echocardiography, and they systematically studied this in 60 patients in spectrum of cardiac defects, and they tried to elaborate upon various conditions based on this. And I would think that this was the immediate predecessor of what we know of today as saline contrast echocardiography. Now, this is again one image for you to answer what is the location of the shunt and what is the likely diagnosis. Now, I think for all people who are of my generation and maybe 5-6 years senior to me would find it very difficult because these are M-mode images. But you imagine how Seward and Tajik could interpret all these images to come to the diagnosis of different cardiac shunt lesions. And that is what is all character about. So to summarize the history, I would say that contrast echocardiography was yet another happy accident that was followed with sagacity of multiple investigators, which in turn paved path for a new field of clinical research and development. Soon, contrast echocardiography branched out to the left and the right. And let's leave the left and pick the right. So we picked the right today for our discussion. So these are the right-sided contrast, agitated saline. It creates non-uniform size microbubbles, which are of more than 10 micrometers. And there are some commercially available, which also produces microbubbles of bigger size, but they are more predictable and uniform size. Now, there are various terminologies which can be used for this kind of echo imaging. And as you can see yourself, for me, I prefer saline contrast echocardiography because it tells us about the medium and what imaging modality has been used. Rest all, I guess, is confusion, but they all are prevalent in the literature. Now, what is the physiological basis of saline contrast echocardiography? The contrast effect depends on the acoustic impedance, that is the difference in the density between gas-contained microbubbles and the surrounding tissues. Higher the acoustic impedance, more is the echogenicity. And gas, since it is 1 lakh times less than blood, it produces excellent echogenicity, and that is the basis of why we get such a good differentiation and echo contrast when we inject agitated saline in somebody's vein. Now, how do you go about saline contrast echo? First, you prepare the patient by putting a large bowl IV cannula. Site of the cannula, usually it is left antecubital vein, but it should differ according to the indication, and I'll dwell upon it in the later slides and a few of the cases which I'll show how different sites are used for optimal conduction of saline contrast echography. Now, it is very important that the procedure is explained to the patient, because without the patient's cooperation, half the job is done, but the rest half becomes very difficult. Then prepare the echo machine, because you may be looking forward to prolonged acquisition. So set it to 20 to 30 beats or 10 seconds. Adjust echo sector view and focus, as we all do. And then prepare the agitated saline. Although some of the literature write that you can add blood and it improves the echogenicity, I personally feel that that increases the step, that increases the requirement of absolute asepsis, and then there is a risk of contamination to the patient. So I would suggest 9 ml of saline and 0.2 to 0.5 ml of air. And I think on almost all occasions, I have never been pushed to use blood in addition to this. Remove any obvious bubble if you see, because that would be absolute no-no when you are doing saline contrast echocardiography. And keep the syringe upright. I think that is the basic for any cardiologist who goes in the cath lab, that syringe has to be upright, so that if there is a minute amount of large bubble, that remains within the syringe. And another thing which is not written over here is don't inject last 0.5 to 1 ml of contrast. And that's how you prepare the agitated saline. And I'm sure that quite a few of you must be aware, and I'll not go to the details of that. Now, the most important is prepare yourself, because you can prepare everything else, but if you don't prepare yourself, you can't interpret saline contrast echocardiography very well. So first of all, why are you doing? Which vein is the best for injection? And I'll elaborate further. Any contraindication. According to the FDA, obvious right to left shunt is a contraindication. Pregnancy is a contraindication. The first one, I don't believe, and I'll share why I don't believe. Now, this is a statement which was published in Journal of American Society of Echocardiography in 2014. And it says the same thing which I just mentioned to you. In the setting of corrected or uncorrected congenital heart disease, there is emerging evidence that contrast may be safe and useful. Although they are more talking about commercial left-sided contrast, but I think it practically also includes saline contrast echocardiography, because much of the evidence which they have included while putting these guidelines together also includes the era when saline contrast echocardiography was prevalent. And this is our own analysis in our own review, which was published in 2015. And as you can see, multiple studies, multicentric, very large number of patients, including a large number of patients of definitive pulmonary AVM in relation to hereditary hemorrhagic telangiectasia have shown that saline contrast echocardiography is safe. And these episodes, sometimes if they happen, are also transient, and there are no reports where permanent damage or neurological deficit has happened to any patient who has undergone saline contrast echocardiography. In our own experience at AIIMS New Delhi, We have not observed a serious neurological event during this study, even in patients with significant right to left shunt, in more than few hundreds of patients studied over the years. And this I am talking on behalf of almost everybody in the department. Now, coming to the indications of saline contrast and echocardiography. Now, these are some of the standard indications: augmenting the right side visualization, to improve TR signal, for better delineation of the RA or RV mass, to improve definition of RV endocardium. I'll not go into the details of this because I think that these are quite standard, and I'll go to the other parts of saline contrast echocardiography. Now, detection of ASD with left to right shunt used to be done in earlier era when echo was not so great. Now, with the advent of good echo imaging and color Doppler, I don't think this remains an indication, although in some obese patients with poor acoustic window, putting saline in may still help, especially if you have a doubt about whether the septum is thin, fossa ovalis is thin, or actually there is a defect. Now, other indications which can be done or used in the ICU setting are confirm RA position of the CVP line in ICU, deciphering unusual course of CVP lines. For example, if it is gone through the left side into CS into RA, then contrast can easily differentiate, and you don't need to wait for an X-ray for you to assure yourself that you are right in position. Better visualization of thrombus in pulmonary arteries in cases of pulmonary thromboembolic PH. These are some of the standard indications. Now, this is another indication which now people are using more often in the cath lab to make themselves sure about the needle in the pericardium. And for the benefit of all the attendees, this is the heart which shows up the contrast in the pericardium. It confirms the position of the needle, puncture needle in the pericardium, and then we are sure that we are not entering into the heart when we are tapping the pericardial effusion. Now, the next one is to rule out right to left shunt, and that is what we call negative saline contrast echo. And I'll tell what it is. So when we inject in any peripheral vein, because the microbubbles are big, more than 10 micrometers, they are trapped into the lungs and they are filtered out from the circulation, and they do not reach the left lung, left heart. So the left atrium and the left ventricle remains clean, free of any bubbles, as you can see over here. So if you don't see a bubble, you practically rule out right to left shunt. Minute maybe, but any significant shunt is ruled out. Now, other indications are detection of different types of right to left shunt within the heart or outside the heart. Most common indication we all know is patent foramen ovale, pulmonary artery venous malformation, cardiac shunts at the level of atrium, ventricular, outer pulmonary level, pulmonary ductus patent ductus arteriosus, or sometimes in post-surgical settings when you can look at the leaks or fenestrations in surgical baffles, anomalies of systemic venous connection or unusual shunts, unusual systemic to pulmonary venous connection, and I'll show some of the examples which will demonstrate how this contrast can be used. And there can be some more exploratory indications by which we can differentiate some of the complex things without the use of advanced imaging modalities. So this is what we are going to discuss today, and I'll not be discussing the previous indications, which anyway are quite standard and are possibly known to you all. Now, this is another one, fun quiz 5. What do you see? And I'll tell the answer in the later part. Now, as I showed this image earlier, this is the normal expectation when we put the contrast in. And I also told that lungs actually gives the signal of no left turn. So it doesn't allow the bubbles to enter into the left side. But if it enters, then you grade it in a semi-quantitative manner by saying grade 1 if it is less than 20 bubbles, grade 2 if there are more than 20 bubbles but there is an incomplete opacification, and grade 3 if there is complete intense opacification of the left-sided chamber. Now, this is what we call grade 0, grade 1, grade 2, and grade 3. Now, why it is important to grade? Is every bubble important? Does any bubble matter on the left side? is the appearance of a single bubble or few bubbles is important. So this elegantly done study on 190 patients of pulmonary AV fistula, they said that the overall diagnostic performance of contrast echocardiography was sensitivity of 100 or 1, specificity of 0.49, positive predictive value of 0.32, and negative predictive value of 1. The positive predictive value for different grades, 0 for grade 1. So if it is grade 1, of course it is 0. If it is grade 2, also it is quite low. So they went on to suggest that if the contrast bubbles are very few, although they described grade 1, 2, 3, they further said that if the contrast bubbles are much lesser, say 5, 10, 5 to 8, then you may still think that this pulmonary AVM is not of significant size and you may not proceed with further thing because it is not going to be hemodynamically significant. But like many other things in medicine, the bubble count has to be contextualized. And why I'm saying so is because a small shunt in the setting of PFO is not same as small shunt with PAVM, because in PFO, we are dealing with something else and the risks are different. So the grading for PFO contrast echo is slightly different, and there people use a cutoff of 10 to say less than 10 would be small, 10 to 20 would be moderate, and anything more would be large shunt. Now, can there be false positive? As everything else, not all that glimmers is a shunt. So a few bubbles less than 3 may occasionally be seen. A forceful injection in pulmonary artery or using central venous pressure line may generate a few bubbles which might cross the capillaries, because if it is very forceful, you might generate one or few bubbles which are smaller than the size of the capillaries, and it would allow it to slip through the lung capillaries. And soon after exercise, because post exercise, there are studies which suggest that there is dilatation of the capillaries and the bubbles may slip through immediately after exercise. Now, can there be false negative? Yes, if your contrast injection is not good, if your provocative maneuvers, if you have used, are not good enough, and if there is large eustachian valve, then it can be false negative if you are performing the injection from arm or jugular saline, jugular vein, because eustachian valve will deflect all the agitated saline towards the right ventricle. So in such cases, a test should be repeated from the femoral side if clinical suspicion is high. Now, coming to the most common indication of saline contrast echocardiography in today's era, patent foramen ovale. And just to summarize about saline contrast echocardiography in PFO, femoral is better than arm or jugular vein. Repeat from femoral if clinical suspicion is strong. Provocative maneuvers improves the yield, and most commonly studied is the Valsalva maneuver, although others also can be used like abdominal compression, coughing, or standing. Always tease the patient what he or she is expected to do. Otherwise, believe me, at least a quarter of your studies are going to become negative if your patient is not understanding what you are trying to say, and that will just result in a poor study. Also, TE is perceived to be better. Why I'm writing perceive, I'll tell in the subsequent slides. Performance of provocative maneuver during TE is difficult, although it can be simulated. Valsalva can be simulated by breath hold, but only if the patient is under GA. It cannot be done if you are doing awake TE. Typically, it is believed to cause early right to left shunt. Patent foramen ovale is believed to cause early right to left shunt. Early means less than 3 beats, late means more than 3 beats, and that is how traditionally it has been told that you differentiate between intracardiac and the extracardiac shunt, and I'll dwell upon it little in detail somewhat later. Now, this is the largest study of saline contrast echocardiography on 1162 patients of patent foramen ovale, and look what they say. 403, 35% patient had some shunting on saline contrast echocardiography. Of these, 48% were positive only with provocative maneuvers. And they also went on to say that there was strong agreement between transthoracic and transesophageal echocardiographic findings. So the perception that TE may be better for PFO may not be as great as we generally think. Now, this is what happens if you are doing this study on rest And if you are doing it after a properly performed Valsalva, and you can see that there is no doubt whatsoever here, and there is almost every doubt on the earth which you can make on yourself if you are seeing this resting study. Now coming to pulmonary AV malformation, this is the prototype intrapulmonary shunt, typically believed to cause late right to left shunt, and I defined what is late right to left shunt just now. Now this is what we say, typical grade 3 late right to left shunt, and as you can see over here, right side of the heart is opacified, and then after a few beats it comes on the left side and it enters into the left ventricle. Now this is fun quiz 6. Any comment about the location of PAVM? If you have, you can write in the chat box. After a few slides you will come to know whether you were right or wrong. Now, as I just mentioned, that there is a lot of hype about 3 to 5 beat rule, and this 3 beat rule was later challenged, and people started using 5 beat rule to differentiate between intrapulmonary, intracardiac and extracardiac or intrapulmonary shunt, and that is how it was named as 3 to 5 beat rule. As it is said in today's time, you should check everything. So let's do the fact check. Now these are different forms of PFO. Which says long tunnel type when it is more than 8 millimeter. There can be multiple openings. There can be a septal aneurysm. These can be hybrid defect. There can be Eustachian risk. And as you can see over here, this is the tunnel of PFO. And this article in 2010 elegantly described different morphologies of PFO. Now, is this shunt intracardiac or extracardiac? This is RPA to LA fistula. This is RPA. This is LA. Now, which rule will apply over here? 3 less than 3 or more than 3? I'm not sure myself. Okay. How about this? This is surely a pulmonary AV fistula, but so much of dense filling that you have almost used a dozen of coils to block this, and still there seem to be some filling of the arteriovenous malformation. Now, do you think that it will not cause a shunt which is torrential? So all these questions we'll answer, but before that, let me share with you what more can be deciphered from a saline contrast echocardiography of a patient with pulmonary AV fistula. Now this is the same image. Now you try and focus over here. Now this is the site of right upper pulmonary vein, and if you see carefully, if I scroll it slowly, you would realize that the bubble actually appears first in the right upper pulmonary vein, right lower pulmonary vein, sorry. And I think you all can appreciate that it starts from here. So it in a way, it localizes the pulmonary arteriovenous malformation to the lung lobe. So this patient actually turned out to have right lower lobe malformation, and then it becomes easy for us to save some contrast, save one imaging modality on CT, and while doing DSA and doing embolization of these malformations. Now coming back to our question, whether 3 to 5 beat rule is such a sacrosanct rule, whether it is the rule to be followed all the time to differentiate between all these intracardiac and extracardiac shunts. Now this paper, I'm sorry. Okay, so this paper says that use of saline contrast echo timing to distinguish between intra and extracardiac, and it says failure of 3 to 5 beat rule. I'm not going to the details. I'm just saying that sometimes it is possible that the rule is bent on the either side, and I have just explained why it can happen. So don't follow the rule like a line on the stone, but you change according to the company it keeps. Now I think this is by mistake over here, so let's remove that and go over here. Now, since we have discussed the indication, how to do, how to prepare, now let's see some examples. Now this is case study 1, 18-year-old boy, central cyanosis since early childhood, normal examination, saturation 85%, saturation on ABG 94%, PaO2 85, normal echo. So it is cyanosis with otherwise normal heart. And so we do saline contrast echo, and what does it show? It shows negative. I'm sorry about that. So this patient, actually we could say that shunt is negative. So we went ahead and did the coaximetry, and it showed that the patient actually had methemoglobinemia, and it was an easy way to differentiate and rule out right to left shunt. Now this is another boy, 12-year-old boy, deep cyanosis since early childhood, clinically no murmur. Just a minute. Okay, clinically no murmur, normal heart sounds, normal chest radiograph, prior evaluation shows no sizable PAVM on CT. And this is the contrast echocardiogram of this patient from the left arm. And as you would see, the saline comes on the left side, this time from the left pulmonary vein, suggesting a pulmonary AVM from the left lung. Ultrasound and CT abdomen then showed Abernethy malformation. And this is just to emphasize that CTA may miss diffuse microscopic PAVMs, especially if it is bilateral. So saline contrast echocardiography may be more sensitive in such cases in picking up these right to left shunt lesions. Now this is another 6-year-old girl, mild cyanosis, saturation 90%, mild cardiomegaly, normal heart sounds, no murmur. Again, cyanosis with otherwise normal heart. Now what are we dealing with here? Echocardiography shows normal heart, almost normal heart, all no RSVC, good size concordant AVBA connection, but RSVC appeared to go to LA with right upper pulmonary vein to right superior vena cava, but the confidence was not so much. So we did contrast echocardiography. So this is subcostal inverted view. Just for your clarification, these are marked over here. So this is the left atrium, which is free from the saline contrast bubbles. This is the right ventricle, and this is the right atrium, this is the right ventricle, and the contrast comes from the IVC. So this injection is made from the lower part. I beg your pardon, it's written by mistake over here. And the same injection, when was performed from the left arm vein, it actually opacified the left atrium and the left ventricle. So it suggests that the SVC is actually directly connected to the left atrium, which then fills the left ventricle. And this is what we call anomalous SVC to left atrium. And why? Because the injection from the lower limb, from the IVC, did not show any bubble in the LA, which means that IVC is normally connected to RA, but the SVC is anomalously connected to the left atrium. Now this is another case, 3-month-old male infant with heart failure with no apparent congenital heart disease, minimal desaturation, normal heart sounds, and no murmur. Careful evaluation of the patient confirmed that the patient had veno-cavernous malformation. But then again, on clinical suspicion, patient was taken up for saline contrast echocardiography. And as you can see over here, I'll play again from the beginning. This is the right SVC from which the contrast injection is coming, and then it is filling the left atrium and the left ventricle before anything is filled on the right side. And it again suggests that the right SVC is anomalously connected to the left atrium. So saline contrast echocardiography can easily help if your normal echocardiography is getting confused because of the additional lesions within the heart or outside the heart. Another case, 13-year-old girl with cyanosis since early childhood, presented with dyspnea on exertion class 3, normal heart sounds, no murmur, but deep cyanosis. And as you would think, we ruled out pulmonary AVM. There was nothing significant over there, but this is what the contrast echocardiography showed. And from all the places, whether you do from left arm, whether you do from right arm, whether you do from left leg, almost every time the contrast was appearing first in the left atrium, entering into the left ventricle, and some bit of it was getting into the right atrium and the right ventricle. And you can also notice that the right atrium and the right ventricle are much smaller than relatively dilated left atrium and the left ventricle. Now, this was a case of total anomalous systemic venous connection, where the SVC, as confirmed by the arm veins, and the IVC, as confirmed by the left leg vein injection, was anomalously draining to the left atrium. Now, this is the paper we published based on this, and this was further confirmed on catheter angiogram. And so saline contrast and echocardiography gave us a lot of confidence as to what we are dealing with. Another case, this one was really tough for me when I first saw. 3-month-old girl infant, minimal cyanosis noticed by pediatrician, normal heart sounds and no murmur, saturation 90% on room air. Echo showed 5 millimeter ASD with left SVC to CS with small connecting cava. Question is, why cyanosis? At this age, it's very, very unusual to have pulmonary AVM of such nature, which would cause so much of desaturation, although it can happen, but it's unusual. And these were the echocardiogram. So as you can see in this parasternal long axis view, this coronary sinus was quite redundant, and it was getting through the mitral valve into the left ventricle to some extent. And this was the color Doppler. And as you can see over here, it seems all fine here, that the color flow in the coronary sinus is as good as you want. But then question was, what is the cause of cyanosis? Now then we did saline contrast echocardiography. Now this is actually not fun quiz, but I guess by listening for almost half an hour into this talk, now you would be able to make a guess, an intelligent guess as to what is happening in this case. I'll not be able to listen to your answers, so you may write in your chat box, but I'll just tell what we did then. So we performed saline contrast echocardiography from the left arm, and as you would see that something is appearing in the left ventricle. Now, just like angiocardiograms, if you see the saline contrast echocardiography as it is, as you have acquired, it becomes quite difficult. So what you do is you freeze it and go frame by frame, and you see, you will know when and what is happening inside the heart, what course these bubbles are taking. So as of now, this is the coronary sinus. Everything looks good. The contrast appears into the right atrium, into the right ventricle, and you are almost ready to say, oh, everything is fine. Why the hell you are bothering me? But then look at this. This contrast from the coronary sinus gets into the left ventricle. And that is the importance of playing it slow with intention to reach to a conclusion. And this is also to emphasize what is the importance of setting your echo for acquisition of more than 10 to 15 beats, or at least 2 to 3 seconds. Otherwise, you would have missed it. So this is to highlight why it is important to do saline contrast echo the way it is advised. Now the question is, why contrast Doppler missed it? The part of the problem here is, one, the contrast doesn't pick small bit tiny flow which happens. And one of the reasons for that is, if you look at this frame rate, it is at 21 hertz, which means that you are scanning the heart at 21 frames per second. On the other hand, when you are doing saline contrast echocardiography, it is 59 hertz here. So it's all more than 2 times that you are scanning the heart. So your chances of picking any small shunt is much higher. And I'll admit to all of you that this is not a great saline contrast echocardiography. If you adjust your sector very well, if you adjust your depth very well, then you can go up to 150 to 180 hertz of frame rate, which is very high and which will be very easy to understand the physiological or pharmacodynamics of this saline contrast within the heart. And it makes the life easy when we are interpreting these images. So as I just explained, saline contrast echocardiography permits imaging at very high frame rate because you are not dividing frame rates in giving additional color imaging, so that your echo crystals are just working to pick the 2D images, and it is nothing to do with the color images. Saline contrast echocardiography follows physiology much more accurately than what color can do. Now let's get out of the heart for some time and see what is there for us. Now this is Case study 7, 18-year-old boy, dyspnea on exertion class 2, loud single S2, no murmur, no cyanosis, negative saline contrast in apical 4-chamber view. So the clinical diagnosis was pulmonary hypertension with possible shunt. But this was echo. I'm using this echo and again, but actually this echo belongs to this patient. As you can see over here, that there is some right ventricular hypertrophy also, which suggests that this patient actually had PAH. Now looking at this, some of us may be prompt enough to say it's negative, no shunt, so it's possibly idiopathic PAH. But my friends, the catch is here that you have not chosen the right view to look at the saline contrast. Now look at this now. Focus on this arrow. Okay, for the benefit of everybody, I'll just scroll it slowly. You can see some bubbles getting into the aorta from PA, and this is a case of hypertensive PDA causing severe PAH. If you don't do this, you are likely to tell the patient that you are idiopathic PAH, and we know that management and the outcomes of these patients are quite different. So it makes sense why it should be diagnosed. So if you can see here, you can see that seepage of bubbles into the aorta, descending aorta. As I just said, that scrolling through frame by frame is important to make the correct diagnosis at the right time. Now another case, 15 months old boy, clinically left to right shunt with hyperkinetic PAH, but there is no ASD, no VSD, no PAH. So the clinic assessment says it is pulmonary hypertension with possible shunt. But then imaging is not great to say with the confidence that what we are dealing with. So again, we took the help of saline contrast echocardiography, and you can see over here that this is parasternal short axis view. This is the contrast getting into the pulmonary arteries from the RVOT. And I think you focus on the initial part, that it is getting into aorta. So once it is reaching aorta, there has to be a right to left shunt. Now, whether it is reaching into aorta early in the phase or late in the phase, if it reaches very early, like it is happening in this case, it suggests there is direct communication between pulmonary artery and aorta. So in this case, we are dealing with aortopulmonary window, which is another treatable lesion if picked up in time. So note that it cannot be picked up on color echo, but yes, in the beginning, it may pose challenges to not so experienced echocardiographers. And at that time, saline contrast echocardiography can save the child from radiation involving procedure like CT angiography. Now, how to interpret saline contrast echocardiography? So where is this agitated saline injected? Where does bubble contrast appear in the heart? When does bubble contrast appear in the heart? And what is the sequence of opacification? And when I showed you some of the images, I tried to tell you what is happening. What we did not discuss much was this. Where is the agitated saline injected? And to emphasize upon this, I'll share with you an algorithm to analyze a venous contrast study. So you give agitated saline. If it is confined to the right side of the heart, it is normal. If it is not, then it is the abnormal study or a positive saline contrast echo. It may happen that it first appears in the left ventricle when it is VSD with pulmonary stenosis. It may also happen with VSD with PAH. It may also be the case that it may appear in first in aorta, in which cases it is ascending aorta, then it is AP window. If it is descending aorta, then it is PDA with PAH. But if it appears in atrium, then we have to look at which atrium first. If it is a right atrium, it is a normal. Bubbles in left atrium, no, then you can again say that this is normal. But if it appears in LA thereafter, after RA, then if it is immediate, then most likely you are dealing with the interatrial shunt. as we just discussed some time back, or if it is after few beats, then it can be pulmonary AVM or direct LA to PA to LA fistula. Now, I discussed what is importance of that 3 to 5 beats rule, and we have to keep our eyes open when we analyze this effect. Now, if it is appearing in the LA first, then it depends upon where you are injecting. If you are injecting in the left upper lobe, left upper arm vein, then it can be left SVC to LA. It can be left SVC with unroofed coronary sinus. If it is in the right arm vein and you are getting the bubbles in the left atrium, then it can be SVC to LA. Or if it is the leg vein, then it can be IVC to LA. And if both are showing this, then it can show, it suggests that it is total anomalous systemic venous connection, as I just shared with you. So in presence of ASD or connecting cava, bubbles may appear in RA even when there is abnormal connection to LA, and that must be kept in mind whenever we are analyzing such a case. Now, some important reports from the literature. Now, this case, just by doing saline contrast echocardiography, the authors of this article, which was published in 2012, could confirm the physiological and anatomic basis of a mass lesion, which was seen in the relation to left atrial appendage, and they almost made up their mind that this patient is actually having a left atrial mass. But once they did a left arm injection, it became clear that this is actually not a mass. It was actually intra-atrial course of left SVC to RA, whereby left SVC directly reaches RA without going through coronary sinus. It's a rare anomaly, but it was elegantly picked up by them just by doing this saline contrast echocardiography. Now, this is another case, a rare entity, crossed SVC. The right SVC goes to LA. As you can see over here, when the contrast is injected on the right side, nothing is filled. The coronary sinus doesn't fill, LA doesn't fill, and LA-LV are filled. But when the injection is made on the left side, then it fills the right atrium. So it is crossed SVC, right SVC anomalous to LA, left SVC normally connecting to RA. And this was published in Circulation in 2006, again elegantly picked just by simple saline contrast echocardiography. Now, this is another case, 15-year-old boy, loud P2, no murmur, referral diagnosis mild PAH. Now, if you see these images, I think some of you who follow me on Twitter would have seen these images, and I think you would not think that these are, anyway abnormal. This looks fine. Circle and sources, bifurcating MPA to RPA and LPA, and so is the case over here. But then what is happening? Now, look at this. So we did saline contrast echocardiography. And I think some of you would have already picked that the saline is already retained within the LPA and nothing goes in the RPA. This becomes further clearer on this injection. Intense contrast in SVC, fills the SVC, RA, RV, and then it fills the MPA. But then it doesn't reach RPA. So what is the problem? So this case actually had anomalous RPA from aorta. And now if you can see over here, these images, upper two images, were so confusing that they almost made us believe that this patient actually has normal pulmonary artery connection. But in reality, what was happening was RPA was coming out of aorta and LPA was continuing from MP. Now another case, 2-year-old boy. Now these are some of the exploratory things which I thought I'll share with you, because these are not conventionally thought as indications for saline contrast echocardiography. Now this patient, 2-year-old, tetralogy with doubtful additional VSD. Surgeons were otherwise ready to do surgery, but wanted a CAT study to document additional VSD. So I just offered, why not do a contrast echo and show? So let's see whether we were able to show something. So now this is the echo of this patient. Now if you see here, now this is RA, RV, LA, LV, and this is the large VSD. Again, we will do our usual assessment of going right from the beginning. You can see over here that there is no contrast in the beginning. Then it comes from the VSD. But if you see over here again, it's not stopping. Let me just. So if you see over here, this part of the LV is getting filled by some contrast, but where does contrast appear in this area? That is how you analyze angiocardiograms. So similarly, you analyze your saline contrast echo, and then if you analyze it well, you will realize that there is something in this distal part of the septum. And once you have suspected, I think it is not so difficult to confirm or refute a diagnosis. In the contrast, you look at this image from tetralogy patient who does not have any additional VSD, and look at this. Again, I will pause here and I'll make you all see. This is the integrity of the interventricular septum. Contrast is on the either side of the septum. This is the right ventricle, this is the left ventricle, this is the inverted view, and it shows that there is no additional breach in the septum. So this patient is unlikely to have additional VSD. So I think if it is carefully done and properly interpreted, then it has a lot of potential to investigate even some of the unusual cases. Now, this special case comes from Sri Chitra, courtesy Dr. Deepa and Dr. Krishnamurthy. And this is in review in journal Echocardiography. This is a 7-year-old boy with a diagnosis of ASD and PAPVC of left and right upper pulmonary vein with unexplained desaturation. CTA didn't show sizable PAVM, and presence of ASD hampered the interpretation of saline contrast echocardiography. And they beautifully showed why it may be important to get into the heart, get into the pulmonary artery, and inject saline contrast over there. So they performed TE with agitated saline into the pulmonary artery. This is the lower pulmonary arteries, and these are the, this is opposite. This is the upper pulmonary arteries, and these are the lower pulmonary arteries. Now, since upper pulmonary arteries, the veins are anomalously connected, it fills the right atrium, and the lower pulmonary arteries, since they are normally connected through the lower pulmonary veins to left atrium, it fills the left atrium. And they could confirm that this patient had, in fact, bilateral diffuse pulmonary AV malformation. And they also went on to confirm that the case was having a peripheral Abernethy malformation, a type of portosystemic shunt, which is known to be associated with diffuse pulmonary AV fistula, which may not be picked on CT angiogram. And I've already shared that CT angiogram is not as sensitive in such cases. Now, this is another case, again coming from Dr. Deepa from Sri Chitra. And this case is 10-month-old child, normal echocardiogram, basal desaturation, so much of desaturation, 70%. Only abnormality which was picked on echo was interrupted IVC. And for those who are not pediatric cardiologists who generally are doing adult echocardiography, interrupted IVC is just abnormality of connection. The physiology and the flow of the blood remains normal, so it doesn't cause cyanosis. But this patient had actually basal desaturation, so much of desaturation. This patient also was diagnosed to have Abernethy malformation, and they successfully closed the malformation with the device. And see what happened. This is pre-device closure, and this is a month after device closure. This saline contrast echo turned negative after the test. This is very interesting. So this is a treatable cause of diffuse pulmonary AV malformation, beautifully described and represented in these images. So how did PAVMs disappear? Now, since we have got so far, now let's discuss a little bit about that. Now, I'll introduce this term, and I'm sure a lot of you must be already aware about this hepatopulmonary syndrome. This is a triad of advanced liver failure, arterial hypoxemia, intrapulmonary vascular dilatation. And this intrapulmonary vascular dilatation is not same as pulmonary AV fistula. And that is what may be the cause of these right to left shunt in all these patients, especially if you are asked to do contrast echocardiography before liver transplantation. And if you search in the literature, there are almost at least 100 reports of saline contrast echocardiography in patients with liver diseases. So it is one of the indications where it is increasingly being used. Now, this is what happens. This image I have used previously also. These are the normal capillaries. And when the patient has hepatopulmonary syndrome, what happens is, because of defect in the liver metabolism and its production capabilities, there are problems of vasoconstriction and distal pulmonary vascular bed, and it causes dilatation of capillaries. And according to the most estimates, these capillaries may enlarge from 15 to 200 micrograms, but some people believe that it can go up to 15 to 500 micrograms. And you can believe what will happen if you inject saline contrast saline contrast in such patients. There is going to be right to left shunt in these patients. And in fact, in such a scenario, it may not be wise to use a label of pulmonary AV malformation. It may be good to use a term intrapulmonary shunting, possibly due to IPVD, intrapulmonary vascular dilatation. Now, this typically presents with platypnea or orthodoxia. No presentation on saline contrast echocardiography can be complete without bringing in this term. And in this condition, the patient becomes hypoxic when the patient is standing. So in all such cases where they document or demonstrate hypoxia on standing, it is a good idea to do saline contrast echocardiography in a standing position, and it has been shown that it increases the sensitivity of picking intrapulmonary or even intrapulmonary shunts in cases which causes platypnea or orthodoxia. In hepatopulmonary syndrome, this happens because the pulmonary vascular dilatation is predominantly in the basal regions of the lung, and that is why once the patient is standing up, the shunt increase multifold, and it causes more shunt to become apparent. And saline echocardiography has higher sensitivity than even ABG for picking up hepatopulmonary syndrome, and that is the relevance of why we should be aware about this condition. More importantly, this IPVD reverses after liver transplantation, and I think similar must be the mechanism when it disappears in cases with Abernethy malformation, because we know that in Abernethy malformation or portosystemic shunt, there is some shunting away of the blood, of mesenteric blood from the gut or from the liver, and it doesn't include a lot of liver substances. So this is what I think about the case. So to summarize, saline contrast echocardiography was yet another happy accident which happened to us, and it paved path to almost a new modality which is unfortunately not used very often. A careful interpretation of optimally performed saline contrast echocardiography is extremely useful, as I illustrated in some of the examples. And a tagline I would say is, bubbling right is the key, and bubbling right includes everything from patient selection to site selection, to prepare the injection, to prepare yourself, to select the echo settings, and almost everything which is included in performing an optimal saline contrast echocardiography. Thank you so much. Thank you, everybody.
Thank you, Dr. Saurabh, for such an elegant and wonderful description of saline contrast echocardiography. And I think you showed some of the once-in-a-lifetime cases of such a huge collection of cases that you have. And some of the comments that have come are like Dr. Gulshan Rai has suggested that a three-way cannula can be used and may add 1 ml of blood that may increase the visibility. Like, what's your comment that? Like,
as already I have highlighted that it is written by some of the clinicians that it increases the echogenicity, but personally I have never used it and I never needed it. I feel that if you do it, you are fixed to only one cannula site. It may be possible in adults, but then it becomes difficult in children because you have a limitation of the cannula size. So I would suggest that you do without that. If you end up not having good echogenicity, then try doing it.
I think I agree with you. Another problem that happens commonly with when you use blood in, especially in echo lab. So cath lab is different ballgame. You can easily get the blood and use it and even there is a spillage happens. That's not a problem. But at times there is quite a bad spill that happens when you're preparing the saline. So once you have blood in it, then you have to be really careful not to do that spill into your staff and everybody.
And the patient and patient relative is there to see you.
Yeah.
So that always remains.
Another comment from Dr. Raghukrishnan Swami is that in TE, can we get some scanty delayed bubbles in a TE when you're doing a TE?
As I highlighted, if the injection is made very forcefully using a central venous line, and if the person who is agitating the saline is very vigorous, I think you can create 1 or 2 bubbles which may be of the size which may pass through the and these microbubbles are deformable. They are not static in size. So when they pass through the capillaries, they may be deformable. So 10 micrometer may become 7 and then it may pass through. So I would say that I will not be surprised to see 1 or few bubbles of that.
And then Dr. Sridhar Balaguru has asked about what are the other conditions apart from PS and PH that you suggested where there can be a right to left shunt across an ASD that can be demonstrated by a saline contrast echo.
Yeah, I did not discuss it over here because this was not the topic, but there are a whole lot of conditions which can cause right to left shunt across ASD. One of them is if the IVC is streaming through ASD, if there is a large eustachian valve, or if the compliance of the right ventricle because of prior MI or cardiomyopathy, then the compliance of the right ventricle doesn't allow the RA emptying into right ventricle, and then there may be a preferential right to left shunting. And then the addition of anomalous systemic veins can do this problem.
So another thing is Dr. Amit has asked, he wants to for you to summarize which vein to be used for which SPC anomaly or which venous system anomaly.
So I can share my screen and go to the algorithm again. Will that be all right?
Yeah, it should be all right.
Yes, sir. So I'll do that. So I'll quickly go to that. So I think if you think logically, if you are remembering the anatomic connections, then it becomes pretty easy. If you are using upper limbs, then you are talking about upper limb veins. Now, since the most common anomaly is left SVC, so you tend to start with left upper limb. And that arm is usually okay because most of the echocardiographers are right-handers. So it is easy to perform saline contrast for the other person also. So we start with left arm injection. But then if you are not suspecting left arm problem, then you may do from the right arm. But in a patient who doesn't have left SVC, which you can see easily by your 2D or color Doppler echocardiogram, then doing left arm also gives the equally good information about the right SVC. So that is another reason why left arm injection may be useful in almost all the cases. Lower limb injection, I generally have done only when there is a serious doubt about right to left shunt, but not otherwise.
So the one of the last questions that have come is can saline contrast echocardiography can be lethal in any time?
I shared with you experience from almost more than 1,000 patients in different settings, and PFO is a condition which is seen in almost 20 to 25% of population. People have been doing saline contrast echo as well as transcranial Doppler in these settings, and they haven't found any difficulty. And in our own experience, I think cumulatively, if we count, I think we would reach 1,000 among ourselves in the department, and we haven't found anything of that nature unless you have been careless in pushing in a large bubble which can trap into the system and create trouble.
So I think one more question that has come up is explain the correct method of diagnosing PFO in stroke in young by contrast echocardiography.
So I think that is a chapter in itself, but briefly if I have to say, it's very, very important that we do provocative maneuver, because without that, almost 50% of the tests which are going to come positive becomes negative. So use that and use a good injection. Half the time, our injections are half-hearted. So if your injection is half-hearted, please make it full-hearted injection first, and then most of the time transthoracic echo would be sufficient. But yes, TE should be done. So whenever we are doing for PFO, if your injection is negative, and if you are seriously considering PFO in such a condition, then always confirm or repeat the injection from lower limb vein, preferably a proximal vein. Add a provocative maneuver, and if the patient gives any history suggestive of orthodeoxia, then consider making the patient half upright or maybe partly upright. It may be difficult, but then it shows up. T, as I've already highlighted, what are the difficulties, but yes, imaging quality is superior, and we get to see much better images.
So one of the comments by Dr. Krishnaswamy is that chronic occlusion of SVC with superior mediastinal etiologies with collateral from SVC to right upper pulmonary vein can also opacify early right away when you do an arm injection. I think that's fair.
I showed that because I did not want to bombard people with so many cases in such a short time. I did not say that. Indications are many, and if I just go back to that list of indications, I'll just share with you that there are even more indications, and it becomes more useful in the setting of ICUs and surgery setting, where a lot of confusion can be clarified if you are using saline contrast echocardiography. Now, if you can see over here, now it says that unusual systemic to pulmonary venous connection, and it can happen in the setting of chronic systemic venous occlusion. It can also happen in the setting of some of the post-op cases, especially like post-Glenn and post-Fontaine, for those who are dealing with patients with congenital heart disease.
I think thanks a lot, Dr. Saurabh, for such a wonderful, elegant presentation and the discussion that followed. I think it will be quite useful. I would say I think saline contrast echocardiography is the cheapest possible CT scan possible in a patient who has cyanosis and you are not able to find a cause. I think it must be done before the patient actually goes to the room. So all patients whom you are suspecting cyanosis, you are not finding a cause, I think the first best investigation is a saline contrast echocardiography. And I think you should have it ready all the time. It's all about mind. Like you have to have the mindset ready, and I think a lot of things can be unraveled. Thank you, Dr. Saurabh.
Yeah, just wanted to add that last line which I added when I was presenting also, and this is what it is about. Bubbling right is the key. So if you have decided to bubble, do it well, because you should not throw away a modality by not doing it right. So bubble it right to get the correct interpretation and the results.
So we will end the meeting with the message that you should always bubble it right, and this bubble never bursts. Thank you.
Thank you. Thank you so much. Thank you, everybody.